Welcome everybody. Thanks for coming. Today we are going to talk about something completely fascinating in the realm of pain management. We will be talking about sympathetically maintained pain. This is also known as SMP. We'll be discussing the mechanisms and the underlying physiology that makes this process so fascinating. So hang on to your hats. We're gonna cover some comprehensive, yet amazing detail, and it is gonna be hardcore. So let's have some fun and get started. To enhance learning, we have a little quiz. It's good to guess the answer. Question 1. What does SMP stand for? A. Synaptic modification of pain. B. Serotonin-mediated pain. C. Sympathetically maintained pain. Or D. Seriously magnificent presentation. Question 2. What is a possible way to diagnose SMP? A. Nerve block. B. Norepinephrine injection. C. Tactile testing with a microfilament. Or D. Hypersensitivity to cold. Last question. What are possible mechanisms of SMP? A. Ephaptic transmission. B. Neurotransmitter mediation. C. Sympathetic and nociceptive coupling. D. Chemically mediated coupling. Or lastly E. Alpha adrenoceptor sensitivity. That's it for quizzes. Please enjoy the presentation. Melanie will begin shortly.
Hi everyone. Thank you for attending this session. I'm pleased to be the voice of our group talking about our topic of sympathetically maintained pain. Our group, as is everyone's, is multidisciplinary, and it consists of Eddie, who's a physiotherapist, Natasha, who's also a physiotherapist, Jan, who's a therapist, and myself, Melanie, and I'm a pharmacist. The objectives for this session are first to provide a definition of sympathetically maintained pain, or SMP, to identify the possible mechanisms, as that certainly has been the focus of this course, to identify controversial areas and unanswered questions, and there are quite a few of those, and most practically for everybody's work sites is to reflect on implications for treatment. So when you are encountering a patient in your clinic, talking to a patient with chronic pain over the phone, that you will consider sympathetically maintained pain as a potential factor and have a bit of an idea of what modalities might be useful or potentially more useful for a patient who seems to maybe have an aspect of their pain that might be more sympathetically mediated. As I mentioned in the objectives, we are going to start with a definition of sympathetically maintained pain to give us a focus for the rest of this discussion. The term sympathetically maintained pain was first used in 1986, and it was used while explaining the physiological basis for causalgia, which was a previous name for complex regional pain syndrome and other related pains. The definition at that time was that sympathetically maintained pain is characterized by past physical trauma to the painful area, continuous burning pain and mechanical hyperalgesia or allodynia, and relief of pain by sympathetic blockade. So, SMP can be thought of as pain in the periphery that occurs when there is stimulation by the sympathetic nervous system. This slide gives you an idea of all the different actions of the sympathetic nervous system in contrast with the actions of the parasympathetic nervous system that is also included on this slide. I would like you to focus on the sympathetic nervous system, and near the bottom you will see the mention of the secretion of adrenaline and noradrenaline, which happens with sympathetic stimulation, and that will be important as we discuss the mechanisms of sympathetically maintained pain. SMP is a unique condition that occurs in certain situations and implies an interaction between sympathetic nerves and nociceptive sensory nerves in some disease states. This interaction between the sympathetic nervous system and the nociceptive nerves does not occur in normal uninjured tissues or in normal patients who are not injured. It is important to understand that all pain is not sympathetically maintained. We are now going to talk about the mechanisms of SMP. Yes, this is what you paid the big bucks to come in here, and as you know, the mechanisms were the main focus of our Rehab 535 course. First, it is important to understand that the role of SMP in chronic pain is not well understood, largely because there is still uncertainty about these mechanisms. SMP is defined as pain that is maintained by sympathetic efferent nerve fibers, which carry impulses from the central nervous system to the periphery, or by circulating catecholamines, which include epinephrine, norepinephrine, and dopamine. It is very important to highlight that in non-pathological states, the sympathetic nervous system does not interact with nociceptive fibers. We will discuss some of the proposed mechanisms of SMP that attempt to explain this sympathetic sensory relationship. Specifically, there is aphasic transmission, which is a non-synaptic communication between nerve fibers. There's chemical mediation, involving norepinephrine primarily. There's direct sympathetic and sensory coupling. And there's nociceptive fiber supersensitivity, which is mediated by alpha adrenoreceptors. As mentioned, chemical mediation is a proposed mechanism for SMP. Chemical mediation has been supported in the literature. It refers to the ability of the sympathetic nervous system to influence the activation of nociceptive fibers through the release of catecholamines, particularly norepinephrine, which I had highlighted in an earlier diagram showing the sympathetic nervous system. In the presence of inflammatory mediators, sympathetic stimulation increases the activity of nociceptors. Inflammation also directly sensitizes nociceptors to catecholamines. Postganglionic sympathetic fibers are a source of bradykinin-induced prostaglandin production, with prostaglandins being released from sympathetic terminals and inducing a mechanical hyperalgesia. Direct intradermal injection of adrenergic agonists result in hyperalgesia. This process depends on an alpha adrenoceptor activation of postganglionic fibers, producing and releasing prostaglandins. The mediation of norepinephrine in sympathetically maintained pain is governed by specific alpha adrenoreceptors labeled alpha-1 adrenoreceptor. Notably, these receptors are expressed in higher numbers in the hyperalgesic skin of CRPS patients. The excitatory role of norepinephrine in sympathetic nervous system activation has been observed in animal studies. Various states of nerve injury, which include nerve transection, partial destruction, and partial nerve ligation, have demonstrated that nociceptive fibers can be activated by the introduction of alpha-1 adrenoceptor agonists. In human studies, use of phenylephrine, an alpha-1 adrenoceptor agonist, increased hyperalgesia in patients with SMP. Additional support for this mechanism is provided by studies in CRPS patients who had undergone successful sympathetic blockade. In these patients, subsequent injection of norepinephrine into the symptomatic skin reinitiated the pain. Norepinephrine administration to a patient with SMP has resulted in increased pain at the affected site, but had no effect on unaffected skin. Other animal studies support this so-called chemical-mediated coupling. Nerve lesions have resulted in the possible increase in activation of alpha adrenoreceptors on sensory fibers. Gibbs and colleagues stated that the alpha adrenoreceptors may be constitutively expressed, meaning that from a genetics perspective, they are transcribed continuously and the receptors are upregulated following a nerve lesion, so the so-called phenotypic switch. Additional sprouting and migration of sympathetic fibers were observed around sensory nerves of the skin. It has been suggested that an upregulation of alpha adrenoreceptors could occur and that receptors could not only be expressed on the nociceptive fibers, but also on associated fibers that could trigger the pain mechanism. It has also been suggested that the increased receptor activation could be a result of an increased availability of agonists to these alpha adrenoreceptors, and that is most likely associated with an increase in sympathetic innervations. However, empirical evidence demonstrating an increase in available norepinephrine is lacking. Yet another proposed mechanism for SMP is the direct sympathetic sensory coupling. Animal studies have shown that following nerve lesions, sprouting of the sympathetic nerves can form baskets, or what I would describe as a kind of scaffold, around the cell bodies of the injured nerve in the dorsal root ganglion. In addition, it was noted that there was an increase in spontaneous firing, increased responsiveness to norepinephrine, and an increase in alpha adrenoreceptors in the involved cells in the dorsal root ganglion. The physical manifestation of the sympathetic baskets does provide an anatomical structure for the sympathetic and sensory nerve coupling. However, it was observed that an increase in sympathetic sprouting in the dorsal root ganglion does not necessarily coincide with a proportional increase in pain behavior, and pain behavior has not been shown to increase with increased sprouting. One author also reported that the functional relevance of sympathetic sprouting into the dorsal root ganglion remains unclear. Certainly, additional research aiming at clarifying this phenomenon and its implications for patients with SMP will be valuable. The final mechanism that we'll discuss is the alpha adrenoreceptor supersensitivity. It seems that, as alluded to in the chemical mediation section, there doesn't seem to be an exposure of alpha adrenoceptors to increased concentrations of chemicals like norepinephrine, but that the responsiveness of these receptors is heightened, or that there is an increased expression of the receptors. Tissue trauma creates an inflammatory response resulting in a type of chemical soup with a whole pile of inflammatory mediators, and these can sensitize receptor responses. In certain populations of CRPS patients, administering increased doses of norepinephrine resulted in greater vasoconstriction than in control subjects, suggesting adrenergic sensitivity. This sensitivity could possibly contribute to non-pain related symptoms such as changes to autonomic function commonly associated with CRPS. Such symptoms could include changes in limb temperature, non-temperature dependent sweating, and vasoconstriction. As far as the clinical relevance of sympathetically maintained pain goes, we have three different professions represented in our group. We have two physiotherapists, Natasha and Eddie, one therapist, Jan, and a pharmacist, myself, Melanie. So we've each thought about how we would, or what the implications would be of sympathetically maintained pain for our treatment of patients from our perspective as the different clinicians. So first, with respect to physiotherapy, the primary goal of physiotherapy is to reduce pain and the secondary effects of immobility, which can be often associated with sympathetically maintained pain. Most importantly, the treatment is needed in the acute phase before the sympathetically maintained pain develops into the full chronic pain syndrome, and certainly treatments in the later stages of this condition can become significantly less effective. Modalities like transcutaneous electrical nerve stimulation, so TENS, may be beneficial in the initial phase of sympathetically maintained pain, which is associated with vasodilation. And that's when functional impairment is minimal and the nerves seem to be less irritable. TENS can provide relief over a period of time, which can enable the therapist to work with the patient to restore functional movement. In addition, caution must be taken to avoid increasing pain levels, as this can certainly lead to an increased irritant focus, which in turn leads to a joint reaction with swelling and stiffness. And using methods of minimizing sympathetic stimulation may be useful here, particularly for these patients with sympathetically maintained pain. Biofeedback is a newer concept in which patients learn that they do have some control over their condition by altering the sympathetic activity, including vasomotor responses such as blood pressure, heart rate, and skin temperature, through focusing on controlling their thought patterns and breathing. And this may be a particularly appropriate modality for patients with suspected sympathetically maintained pain. We also have psychology or therapy represented in our group. Jan is a therapist who works with clients who have mental health and addiction issues. From a psychological perspective, there would not be any specific therapeutic techniques for clients with mental health and addiction issues with SMP, which is sympathetically maintained pain, rather than for chronic pain. Some of the techniques involved in psychological treatment are on reducing arousal and stimulation, which would be expected to be particularly beneficial to a patient with sympathetically maintained pain. Some patients develop addiction in addition to their chronic pain condition, and certainly the presence of both conditions can result in a reorganization of baseline perceptual pathways in the brain that can result in an increased pain perception. By understanding more about the mechanisms of chronic pain, it will allow more effective advocacy and therapy for patients and may provide some explanation for some of the client's symptoms, which may also help with this advocacy and the acceptance of the patients of their symptoms. From a pharmacy perspective, in conditions such as complex regional pain syndrome, where there is thought to be the presence of sympathetically maintained pain in a number of clients, there are some studies showing that the hyperalgesic skin has a greater number of alpha-1 adrenoceptors compared to normal skin. Therefore, when we're thinking about pharmaceuticals, therapeutic modalities such as a sympathetic ganglion block that blocks the sympathetic nervous system, alpha-1 antagonists, so again, blockers of the sympathetic nervous system, so a medicine would be phentolamine, that would be by injection, or things like topical alpha-2 agonists, which are clonidine, and these alpha-2 agonists reduce the norepinephrine relief, and so all of these modalities, by reducing the release of norepinephrine, or the reducing the impact of norepinephrine stimulation, may be possible avenues for pain relief in the setting of sympathetically maintained pain. There are some oral medications such as alpha-1 adrenergic antagonist, prazosin or doxazosin, that could be considered in patients with sympathetically maintained pain who are unwilling to go a more invasive procedure such as a stellate ganglion block. And these are blood pressure type medicines, although human studies of these medicines with sympathetically maintained pain were not found. In addition, when we think about patients who have addiction or physical dependence to opioids, when those patients undergo withdrawal of the opioid, there is actually a significant increase in sympathetic activity. So, and that's just a function of the process of the withdrawal syndrome and the effects of the opioids when they're being taken, and then the loss of this blunting of the sympathetic outflow when the opioid is taken away. So for a patient with sympathetically maintained pain, it could be hypothesized that withdrawal from an opioid may be much more painful than for a patient with sympathetically independent pain due to this increased adrenergic stimulation that results from the opioid withdrawal process. There was no reference that I found to support this hypothesis, though in the literature that was reviewed for this paper. Now we'll talk about controversial areas and unanswered questions. This was quite interesting to learn about, but also very frustrating when we were reading the literature as we're trying to come up with some guidelines and bottom lines for treatment of patients with sympathetically maintained pain, and when there are still a lot of controversial areas and unanswered questions, that does make it quite challenging to come up with concrete information. So a review of the literature identified that there remains a lot of controversy with SMP, as I alluded to. Over the past 20 years, the research has come a long way, but there's still a lot of debate regarding the exact mechanisms, and we discussed that a little bit already. Many researchers believe that with SMP, there may be more than one mechanism occurring at the same time, which then also makes it very difficult to study mechanisms independently of one another, as well as to make comparison between individual cases and patients. Much of the debate surrounding SMP is related to the diagnosis, and typically that is established by an assessment of pain relief during a local anesthetic blockade of the sympathetic ganglia that would be designed to innervate the painful body parts. So blocking this ganglia would be expected to result in pain relief, and this is something that I mentioned earlier in this session. It has been argued that the local anesthetic block, because it blocks both the sympathetic and somatic nerve pathways, could be creating uncertainty as to whether or not the benefit truly is due to a decrease in sympathetic activity. Needless to say, how valid this method is does remain highly controversial. Studies have also shown that local anesthetic blockades of these sympathetic ganglia can be confounded by a large placebo response and may be associated with false positive results. One study that looked at lidocaine versus saline being used to block the sympathetic ganglion in patients with CRPS showed that the saline block produced 20 hours of nearly complete relief. So that obviously would not be expected if the theory is that sympathetic blockade of these ganglion are what's necessary to get relief. So still a big question mark there. On the opposite side of the spectrum, a number of studies have identified that not all patients diagnosed with a condition involved with sympathetically maintained pain do respond to the administration of norepinephrine to the skin, and norepinephrine is one of those sympathetic catecholamines, so a sympathetic neurotransmitter. If by definition SMP occurs when there is stimulation by the sympathetic nervous system, then really the question is, why wouldn't administration of norepinephrine to patients with SMP cause pain response in all patients? And why wouldn't all patients undergoing a sympathetic block have relief of their pain symptoms? One researcher has questioned the possibility that a patient may have two components of pain, aspects that are sympathetically mediated and other aspects that are sympathetically independent, which again complicates the investigation of this phenomena. Another area of controversy has been directed towards the research itself. First, because most of the understanding regarding the mechanisms of SMP has been derived from animal studies. And the problem is that the mechanisms demonstrated in animal studies do not always translate into humans. Specifically, it may be difficult to study SMP using animal models, as the expression and function of the alpha adrenoceptors may differ between species. Questions important to the clinicians that still need to be addressed include how best to manage patients diagnosed with SMP, and how to identify those who are likely to respond to sympathetic blocks, as this is an invasive procedure. Does SMP persist, or is it permanent, or can it resolve? There was one study that followed up on SMP patients after multiple years and found that some patients' pain seemed to have changed to more of a sympathetically independent pain, and one patient no longer had pain of any kind. Again, this complicates the ability to study this phenomena and adds to the potential controversy as well as the unanswered questions. In summary, SMP is a chronic pain condition that sometimes appears with other pain conditions. Studies are largely done on animals, and we've talked about some of the controversy about that and whether that translates into what's really going on in a human patient. There are many hypotheses about the mechanisms of SMP. There is also controversy and an abundance of unanswered questions, and taking a multidisciplinary approach is very important. So trying to access or reduce the impact of this sympathetically mediated pain via a variety of different avenues will certainly be key. Thank you for attending this presentation, and we're happy to address any questions.